So next, I would like to just have a discussion about H.Pylori testing. Who should you be testing? Well, obviously the group we've talked about above, failed lifestyle, drugs review, antacids, PPI course all done. Patients who should have sort of a high suspicion or risk for H. pylori might include those with a past medical history of GI bleed, previous gastric cancer or maltoma, or a strong family history of the above. Patients who have a requirement for long-term non-steroidal use, it may be useful to test for H. pylori. And unexplained iron deficiency anemia after malignancy has been included should really have H. pylori testing as well, as it is a cause for iron deficiency absorption problems. Of course, if malignancy has been included, the patient's probably had an endoscopy, but they may or may not have had a CLO test or a H. pylori test done then. So how do you test for H. pylori in primary care? Well, there's two main tests. There's the C13 urea breath test or a H. pylori stool antigen test. I would certainly avoid serology. The reasons being is serology does not tell you whether there's active H. pylori there. It tells you if there's been exposure to H. pylori. So a patient could have had it, been successfully treated, but will still antibody positive test many years later. So it's not a good test. It's no longer offered in Sheffield. You also get false negatives in the elderly and those who are on immunosuppressant drugs. So breath testing, stool testing is non-invasive. It's cheap. It's around £25 as opposed to invasive endoscopy and a biopsy, which is 300 plus. However, it must be done with a minimum clearance of 2 weeks off a PPI medication or 4 weeks off any antibiotic therapy or bismuth therapy. If the patient really cannot get off their PPI, then you can put them on a H2 receptor antagonist, and they just need to be off for 24 or 48 hours before doing your H. pylori testing. Antacids, alginates can just be stopped on the day. Perhaps something else to say, probably certainly our GI physiology unit, which does urea breath tests, would rather you requested stool antigen tests. It's a very quick test. The patient sends a stool sample off now in the post, and we're all getting used to doing that. Whereas a urea breath test is really a 45-minute appearance, having a urea drink and then having a breath test done half an hour to 40 minutes later. So that takes quite a lot of time. Perhaps one thing to bear in mind, as we said, most of these patients will actually have non-ulcer dyspepsia, and the number needed to treat for H. pylori is about 1 in 14. To improve symptoms, it's about 1 in 9. So a lot of the patients you might give H. pylori eradication to may still be symptomatic afterwards, but certainly a subgroup will be treated. Perhaps more importantly, it is a good prevention for people presenting with ulcers or bleeds in the future. What I would not recommend is H. pylori testing done for patients who have quite obvious or predominant reflux symptoms with a PPI response. H. pylori is not part of the pathophysiology of reflux, so actually looking for it or eradicating it is not effective. Okay, so
yeah, one question, Kumar. Just going back to kind of at the assessment and thinking about kind of other causes of similar symptoms, are there any particular groups of patients or kind of clinical features you'd look out for that would steer you towards doing ultrasound scans?
Yeah, as I say, sort of more localized pain in the right upper quadrant, obviously, is you're thinking gallstones, biliary pathology. Predominant pain radiating into the back is a little unusual for gastritis or simple peptic ulcer disease, although it can occur, but maybe think pancreas then, and some LFTs might be useful. Predominant epigastric pain, worse with fatty foods, all the usual things, and the 4 Fs. The obese patient, female, 40s, there may be particularly if there's been a poor response already to a PPI course, then it may be worth thinking this could be related to gallstones. If you do get to put a hand on the patient, tenderness in the right upper quadrant, non-tender in the left upper quadrant, they're better off with an ultrasound than an endoscopy in those scenarios.
Right. Thank you. Thanks.
So H. pylori treatments, we do get a lot of questions about this, particularly about what's second, third line, you know, what's the best treatments, what do we do for failed treatments? And there's sort of a different direction of change going with H. pylori treatments now, which the UK is actually lagging behind with. We've had no updating guidelines for some 6 years now. Partly the reason for that is the UK does not collect data on antibiotic resistance. So it's difficult to prepare guidelines if you don't know what patients and what antibiotic resistant patterns there are in the country. But
Yeah.
the main issues with H. pylori treatment is prescribing it wrongly, not taking it properly, and of course, antibiotic resistance. Now, the first line standard triple therapy currently NICE and BNF advocated is basically a high dose PPI plus 2 antibiotics, depending on the patient's last 1 year of exposure and allergy status. And you can choose from the licensed antibiotics, amoxicillin, clarithromycin, and metronidazole, and it's a 7-day course. If you're looking at second line or penicillin allergy, you basically choose the alternative antibiotics as above. But my suggestion would be, that's not in the BNF, is to go for a 10 or 14-day course for a second line eradication, because everywhere else in the world now has moved to 10 or 14-day eradication courses because we know they're more effective. If compliance is an issue, some people argue compliance is worse with a 10 or 14-day course, but I would suggest if you have a 7-day course, you'll get 3 or 4 days of antibiotics in. If you prescribe 10 to 14, you might get a full week in. So actually, it might improve compliance. Third line regimes, again, high dose PPI, and start adding in bismuth with different antibiotics. And you've got other options of tetracycline and levofloxacin also involved. And by the time you get into third line, you're definitely talking about 10 to 14-day periods. And then there's more specialist antibiotics such as rifabutin, which I've only prescribed twice in my career. So I would suggest if you're thinking about that, that's probably a referral on to secondary care. Now, there are some issues with these guidelines. As I've said, they're not in keeping with the rest of Europe and the world. A lot of those antibiotics are non-licensed, and we have no current bismuth preparation. The previous one was Pepto-Bismol available in the UK at the moment. We do have an increase in clarithromycin resistance worldwide, also, which is starting to take that antibiotic out. So the way things I anticipate will go in the next year or two, we'll be looking at probably longer course therapies. We do now have a bismuth preparation available in the UK called H.Pylori, which is made by Flynn Pharma Limited. And this is a combination capsule of tetracycline, metronidazole, and bismuth taken with a PPI for 10 days. And this is now the first line therapy in the USA and Europe, and eradication rates are around 95% versus 80-85% with the other regimes. And it avoids the issue of clarithromycin resistance in the Western world. There may be some issues with it for NICE, however, in that it costs around £40 for the 10-day course, which is more expensive than other regimes. It's also 3 capsules 4 times a day, and there's always concerns if you react, which antibiotic was it that caused the problem. So it may not be first-line therapy in the UK, but it certainly is a very useful now third-line therapy at least. So that's something to bear in mind. It is prescribable, it is available, and we're certainly starting to use it in the hospital. Just some clinical tips. One of the reasons for H. pylori failure is actually not ensuring the patient's taking high dose PPI during the course, and you need to be on a twice daily dose, 30 BD of lansoprazole, 20 BD of omeprazole, or even 40 BD of omeprazole. because higher dose acid suppression makes the antibiotics more effective, even in the setting of antibiotic resistance. And I would also suggest that we do get quite a lot of referrals for open access endoscopy for culture and sensitivity of H. pylori. I would suggest this is only useful if you've gone through first, second, third line, and there is a real requirement to eradicate H. pylori, and that may be in patients who are at high risk of gastric cancer, for example, with a family history that you want to ensure you do keep going on at them. I don't know if you have any questions about that, Jim.
Yeah, just thinking about that last group of patients, so people who've failed third line treatment in primary care. So you mentioned open access endoscopy. Would you think that's preferable to kind of outpatient clinic referral for those patients?
Yeah, well, I think if you've had a number of failures of H. pylori treatment, there's often also an issue of unclear diagnosis as well, isn't there? And the patient does have dyspeptic symptoms by sort of definition. So, you know, an endoscopy is something we would probably advocate at that stage, because there are two questions you really want to know. Does the patient still have H. pylori, and is it doing any damage? I mean, if you have a completely normal endoscopy and you're just carrying H. pylori along, it may not actually be the cause for your symptoms. It may not be a problem to leave it there.
Okay.
Obviously, culture and sensitivities can be useful in that you do get the antibiotic sensitivities, but almost always they're predictable, and not almost always tetracycline is one of the sensitivities that is positive on these. So I would suggest a third line therapy with tetracycline before doing culture and sensitivity and referral. And, you know, advice and guidance is available in Sheffield if you have a problem, rather than having to refer to clinic. Or direct to endoscopy if the patient's not keen on that.
Yeah. Okay. Thank you.
So there's then a question, of course, of do you retest if you've given your H. pylori eradication? Well, if the patient gets better, certainly there's no need for retesting. And NICE would say if the patient doesn't have any response to PPI or H. pylori eradication, and the diagnosis is likely functional dyspepsia, there's probably little point in retesting. But I guess if a patient has very good symptom improvement and then gets a recurrence of symptoms later, then it might be worth retesting before giving a further course of antibiotics, certainly. However, the caveat to that is some people do feel temporarily better with H. pylori eradication because they've actually got reflux disease, and the twice daily PPI actually helps them during that time. Of course, they relapse after a couple of weeks because they're not on the BD PPI anymore. And some patients with predominantly bloating symptoms, discomfort, may get better because of the antibiotic effect on the microbiome. And what you've actually treated is possibly small intestinal bacterial overgrowth. So sometimes it is worthwhile retesting, but I would suggest the main group who should be retested are those patients who have high risk problems such as previous maltoma, previous treatment for early gastric cancer, and those patients who've actually had a significant GI bleed in the past, because you do want to make sure they are H. pylori free. And to do retesting, you must ensure the patients are at least 4 weeks, preferably 8 weeks, tested after their eradication therapy. Otherwise, you may get false negatives or false positives. So yeah, leave it a period of time. If the patient cannot come off a PPI, then that probably implies they've got reflux, and you can use a H2 blocker, as we mentioned before, as a bridge to getting a test done. There's risks of treatment. C. difficile, diarrhea is something we've always worried about post Helicobacter pylori, particularly with multiple antibiotic regimes. But in fact, although the risks were put as high as 4.5% in the past, a large study in 22 in the US with 28,000 patients actually showed the risk was about 0.74%, and likely half of that if you took confounding factors out. But be aware if you've got an elderly patient who's had C. diff before, you should warn them that if they do get a persistent diarrhea or are ill with diarrhea or bleeding, then to rapidly get a C. diff toxin test done and get them on vancomycin if needed. I guess people may be unfamiliar with bismuth side effects. Perhaps the only one to really be aware, well, the ones to be aware of is it colours your urine black and stains your tongue. And if you've got soft contact lenses, warn the patient. And bismuth is not indicated for people below the age of 16 because of the rare condition Ray's syndrome, which is a type of encephalopathy seen with some salicylates, which bismuth is one of.